Implementation of the ABCDE bundle and ICU delirium assessment. What is ICU-induced delirium? It is defined as a different state of cognition from the patient's baseline that acutely fluctuates. This ICU-induced delirium is specific to the ICU because of various factors found within the unit. Patients can lose a sense of reality and experience hallucinations and even paranoia, but their delirium can also be obtunded and fluctuate between obtunded and agitation. There are 3 different types of delirium. There's hyperactive, where the patient is very active, agitated, and they can experience hallucinations and paranoia. There's hypoactive, where the patient is sluggish and obtunded and difficult to arouse. And then there's mixed, where the patient can fluctuate between a hypoactive state and a hyperactive state. There are many dangers that go with having ICU-induced delirium. Hallucinations and paranoia can cause the patient to attempt self-extubation and removal of IV accesses. Because of this hallucination and paranoia in the patient, they don't understand why these foreign objects are placed in their bodies, and they feel a sense of danger. So with the attempt of self-extubation, there's obviously this risk of injury and even death if they're successful in their attempt of self-extubation. In this case, the nurse may want to apply restraints, but unfortunately, the use of restraints is also shown to worsen delirium. With ICU-induced delirium, the patient has an increased risk of morbidity and mortality. With hallucinations and paranoia, the patient wants to self-extubate if their agitation reaches that critical level. They also have a lengthened time in their restraints and the exposure to sedation, which can have negative side effects. All of these risks heighten their mortality, and early recognition is the most powerful way to prevent and treat delirium in these patients. Proper training in recognizing delirium is a nursing-powered intervention, and continued assessment for delirium can prevent ICU-induced delirium in up to 40% of patients. By the end of the lecture, the student will be able to differentiate 3 different types of ICU-induced delirium, be able to name 3 different causes for ICU-induced delirium, be able to identify 3 different modifiable risk factors for ICU-induced delirium, be able to define the letters of the acronym ABCDE, and be able to state the steps of the ABCDE bundle. Goals for after listening to this lecture is the student will be able to utilize this information in their clinical practice within 1 work week, manipulate modifiable risk factors for patients to reduce the risk of delirium in practice within 1 work week, be able to educate others on ICU-induced delirium and ABCDE bundle within 1 work week, and implement the bundle in practice. Causes of ICU-induced delirium include non-modifiable and modifiable risk factors. Non-modifiable include age, a history of dementia, or a use of benzodiazepines prior to admission. Modifiable risk factors include facilitating a circadian rhythm, having a clock and a calendar in the room to help reorient the patient to the date and time, giving them their eyeglasses or hearing aid if they're prescribed, reduce noise in the patient's room and from outside sources, such as a television or a radio. Interaction with family members also facilitates remembering and their memory to help reorient them to the unit. And early mobilization is very effective in reducing delirium and also restores a sense of control for the patient. There are some limitations with the modifiable risk factors, most notably the use of sedation. For mechanically ventilated patients, oftentimes sedation includes an opioid or a benzodiazepine. However, the ABCDE bundle includes facilitating reduction of the adverse effects of sedatives by using awakening trials, protocols for sedation, and appropriate choice and amount of sedation given. So what does ABCDE stand for? It stands for awakening trial, breathing trial, choice of sedation, delirium detection, and early mobilization. In an awakening trial, sometimes this is called a sedation vacation. You simply turn off the sedation at the same time every day to assess how your patient reacts. Do they wake up agitated or do they remain very obtunded and difficult to arouse? If your patient passes their awakening trial, you can proceed to a breathing trial. With the ventilator still in place, you change the settings to CPAP, or continuous positive airway pressure. This way, the patient has respiratory support, but it encourages the patient to take their own breath. You assess their respiratory rate and their other vital signs while on the CPAP to ensure that they can tolerate breathing on their own. It's important to remember that their sedation must be completely turned off during their breathing trial. Choice of sedation is also important. Benzodiazepines are not recommended for these patients. Propofol and Precedex are oftentimes used for sedation for these patients because propofol is very short-acting and Precedex is not a narcotic. You always want to check the Ramsey score of these patients every 2 hours to assess a level of sedation. You do not want to oversedate, but you also want to keep them calm. Delirium detection is when you utilize the confusion assessment method specific to the ICU to assess a level of agitation, and you want to do this at least once per shift. The basics of this is assessing their mental baseline. Has it fluctuated at all in 24 hours? If so, they're positive for delirium. Next, assess their inattention. Have them do a simple task, such as squeeze my hand when you hear the letter A, and then spell out save a heart, which has 2 A's in the word heart. If they have 3 or more errors, they're positive for delirium. Also, assess the Ramsey score. Anything other than a 2 is considered delirious. Continuing with delirium detection, you want to ask yes or no questions that have solid answers, such as, will a stone float on water? Or, are there fish in the sea? Then, you want to assess their understanding of commands. You hold up a certain number of fingers, and then say to your patient, hold up this many fingers. Now, do the same thing with the other hand. Even if your patient has a Ramsey score of 2, if they incorrectly answer your yes or no questions and or do not follow the understanding of commands, they are positive for delirium. Last in the ABCDE bundle is early mobilization. Have a physical therapy consult for these patients. And you want to start off with something simple, like passive range of motion, if your patient is weak and unable to stand or sustain sitting in a chair position. Just simple passive range of motion has very positive effects in reducing and treating delirium in your patients. You want to ambulate them at least 1 to 3 times per day, and you want to progress to more active range of motion, sitting up into a chair, standing, and then walking if your patient is able to. And you can use a portable ventilator for your patients. It leads to fewer days on the ventilator and in the ICU when you're able to ambulate your patient early. Sometimes facilities can add the letter F, which stands for further care in the sedated patients. This is taking into consideration other factors that help reorient your patient and reduce delirium, such as your patient's proper nutrition and hydration, reducing noise in the area. You want to facilitate a natural light schedule for these patients, dimming the lights at night and opening blinds during the day. And you want to facilitate a natural sleep schedule. Also, consistent reorientation for your patient when they're awake helps reduce delirium and helps facilitate proper cognition. In conclusion, ICU-induced delirium has devastating effects on these patients, but they're also preventable. While some of the risk factors are non-modifiable, the majority of them are modifiable and specifically are heavily influenced by nurses. And the ABCDE bundle is strongly supported by evidence-based research and is a nursing-powered intervention for these patients. Nurses are the most important team member of the healthcare team in preventing and treating ICU-induced delirium, and the ABCDE bundle is the most effective way in treating and preventing ICU-induced delirium.